Okay, good morning. Welcome back to Favaloro Foundation University Hospital. It's an honor to be with all of you again in this for this live transmission for MedStream. I will introduce the team. First, on my right, Dr. Carlos Pava, Dr. Franco, Christian, and Matias. Juan is a technician for the valve, and here is Germán and Mariano, and behind the controls are Hernan and Claudio and Gustavo as technicians. But today I'd like to thank especially to Dr. Fernando Cura, who is here on my right. He has a lot of experience with the device that we are going to use today. So he's very welcome here, and I am thankful to him for having here. Good morning, Fernando, and welcome.
Thank you very much, Cacho. It's a pleasure for me to be here with you and with Meds.
Okay, let's introduce the case. Let's go with the first slide. Next. Próxima. So she's a 75-year-old lady. She suffers from dyspnea. She has the following risk factor: hypertension, diabetes, also morbid obesity, with a severe COPD with this finding that you can see there. And she also suffered from venous disease with the deep venous thrombosis 2 years ago. Next. In the EKG, she has a normal sinus rhythm with incomplete right bundle branch block. Nothing special about the blood test. The echo Doppler unveiled a severe aortic stenosis with a tricuspid valve with an area of 0.7, excuse me, with gradients of 62 and 40 as a mean gradient, with a Vmax of 4.0, with preserved left ventricular ejection fraction. Clinicians at the beginning were a little confused about the symptoms, so they asked for a stress test echo, which showed the dyspnea with arterial oxygen desaturation during exercise. So we interpret this due to the severe aortic stenosis, so they send the patient or refer the patient for evaluation. Next. She underwent a coronary angiography in another hospital. She has normal coronary arteries. Unfortunately, the quality is not good enough for showing to you today. So, but we accept the angiography, which is normal. Next. So we did an angio-CT. She has these measurements done at the core lab of the valve center. The annulus measurement was with these diameters 20 and 24.4, with a perimeter derived of 22.7, with an area of 377, with a perimeter of 71. Next. This is the LVOT with a little bit calcium below the left coronary sinus, with these measurements at the sinotubular junction that I will show you in the next slide. Next. Próxima. So this is the summary of the measurements: perimeter of 71, perimeter derived of 23, I would say, area of 377. With the LVOT of 24, with the right coronary height of 11, quite 12, and left coronary height of 11.6. Next. Here we can observe the stain of Valsalva, approximately 30 millimeters diameters, with sinotubular junction of 30, with a ascending aorta of 38 millimeters. Next. So we were discussing with Dr. Fernando in the morning, and we did our own measurements. And here we find the different measurements. You can see the area is 424. Fernando, would you like to comment something about this?
Yeah, this is a good point to discuss, because sometimes we find some discrepancy in between the core lab analysis and our analysis. So it's a good exercise to perform our own analysis, just to be sure of which valve needs our patient. So in this case, we have changed our mind to use a 24.5 size Myval.
Great. Great. So that's why we usually do our own measurements, although we have the core labs for 80 valves. Usually we have an agreement, but sometimes when we are in the borderline for a smaller or a bigger valve, we measure and then we discuss and we decide which valve we are going to use. Next.
And one point in this special case is that there's no much calcium.
Yeah, it's something I will show you
okay,
next.
good.
So here is the osmium height, 11.8 for the right, 11.6 for the left. The osmium of the right is quite big. The left is not that big, but for this valve is enough, and Fernando agrees on not protecting this coronary osmium. Next. So here is what Fernando was saying. If you want to comment, we have some calcium, but not too much.
Not too much. So a very important comment for balloon expandable valves is to have a very accurate measurement of the size, probably more important than self-expanding technologies. And second, in this case, without too much calcium, better to have a good size because we don't want the valve to embolize.
Okay, next. So these are the two potential projections for implantation. On the left of the panel, we can see the cast overlap view, which is our standard view for implantation of every single valve. It would be right oblique in 6 degrees and caudal inclination of 27. And the coplanar view is going to be on the left 13 without any kind of caudal or cranial angulation. Fernando, do you have any preference with this device?
Well, so the library is split into groups of physicians. Some of us prefer to use the coplanar view. And if we find that the valve, the stent is not coaxial, we move to the cusp overlap view. But of course, there are many, and there is a trend to use, as you use, cusp overlapping for every valve. I think it's a great learning point that we have in the last few years.
The other issue here is we have an aortic angulation of 57, which is quite important. So I think this is another reason of why we have chosen a balloon expandable valve.
Yeah, this is a great point. This valve, as the other balloon expandable valves, they have a deflectable tip of the catheter that is good in some kind of very acute angulations. So I think this is going to be a great example of the advantage of this technology.
Next. So these are the potential vascular access, quite acceptable, not too much tortuosity, good diameter, 7 in the common femoral artery on the right side that we have chosen for implantation of the valve. Next, note calcium. The aorta is, I would say, quite straight, nothing or no important angulations there, no significant calcifications. Next. So in summary, it's a quite young lady, 75, with severe aortic stenosis and severe COPD and morbid obesity. And this is why the heart team suggested to do TAVI instead of surgery here in Argentina. That 75 sometimes is not that easy to get approval for health insurance. I don't know if you're practicing the hospital something similar.
Yeah, it's very similar. It's very hard, and I have the heart team this morning, and it's difficult to have everybody agree with young patients below 80. No. But there's a trend that above 75 is a very good practice to go for TAVI.
Okay, next. So according to this suggestion, we have prepared this patient for transfemoral, and we also going to discuss with Dr. Cura about the direct implantation or pre-dilatation. Next. This is the valve that Dr. Cura has experienced. Fernando, you might describe.
This valve is a balloon expandable valve. It has a alloy cobalt chromium technology with a very nice skirt, as you see below, with PET technology. So the valve has a length of about 17 to 21 millimeters. It shortens as we open, especially in the below portion of the valve. It has a bovine pericardium leaflet. It's very comparable with Edwards. The only difference is that they have different sizes. They have in-between sizes. They have 9 different sizes.
We have
We next, meanwhile, we can ask the audience if they want to send some question by the chat, so they can be transferred to us and we can answer, especially myself or Fernando. So going back to our discussion before the case, according to the core lab, the indication was the Myval 23. According to our measurements, it was 24.5.
Exactly.
But with the core lab measurements, it was 23 plus 1 cc. In our measurement, it's 24, but nominal, not extra cc's.
Exactly. Yeah, we know that all this sizing, they have different, we have to take care of different measurements, the amount of calcium. In this case, since the calcium is very low, and the size, I mean, we are comfortable with a 24.5. And another point, as you mentioned, is to use as a direct TAVI without predilatation, which is not very usual with this valve, but this case, I think, is a great idea to attempt, at least to have a good attempt to go directly. If not, we can predilate.
Let's show the introducer set, please, Franco. Bring the set to the introductor here. Next slide, please. It's important. Next. Here. Fernando, can you describe, because this is the positioning for the implantation?
Yeah, so this is probably the most important part of this TAVI case. Is going to be to see the bands. You see in the left, the diagram, that it has dense and wide bands, 3 bands in the outflow, and then a separation and another band in the aortic portion of the valve. So we have to try to align the light, the light line according to the annulus position in the cusp overlap or in the coplanar view. So we are gonna be like 70% in the aortic part, 30% in the LV, and then when we open, we hope to be like 90-10 or 85-15.
Okay, great. So this is the sheath. Let me explain what we already have done. She has previous conduction disturbances. So let's go to real life, to the camera 1 or 2. So here we put a femoral introducer for a transient pacemaker that we are going to pace in from here. And also we will leave the wire at least for 12 hours to check if any new conduction disturbances would appear. Remember that we have talked in last session that previous conduction disturbances are the more important predictor for new or worsening. So we have done a crossover, and we have the ancho there. We use a SIM 2 with the extra stiff Terumo wire. Then we advance it, we cross with the 018 wire. We put 2 proglides here, and we have left an 11 introducer set because we are waiting for 20 or 25 minutes before starting the procedure. So here is the introducer. Any special characteristic that you want to point out, Fernando?
Yeah, this is a expandable sheath. So it is 14 as it comes. And then before advancing with the valve, we will open with the 18 French dilator. So it's a expandable sheath, very good.
And this is the dilator that we are going to use before. Okay, perfect. So Franco, please move here. So hold the groin. We will introduce this catheter. We exchange for extra stiff Amplatz wire.
So this is very important to, whenever we use an introducer, a large bore introducer, it's important to use a hard wire, extra support wire. So this is also our practice to be sure that we don't have any problem.
Bring the water so we can clean the hands. Well, anyway, then give me the wire first. So it's also important, I think, when we are doing live cases where we have to wait for some time, it's better to have a smaller sheath so we don't produce ischemia.
Yeah, exactly.
Okay.
And also, this expandable sheath, it doesn't have the same sealing as any other introducer. So it's good to have it to implant the valve, but not for a long time.
Okay. So we are dilated the orifice, the bore.
The skin and the orifice.
And now we are put the introducer, and also Fernando recommended us to suture to fix.
Yeah, because sometimes the sheath may come back, and it's better to have it sutured to the skin in order to avoid that and to keep because you don't want to advance the sheath without the dilator. This is very dangerous. So whenever we have to advance the sheath, we have to put a dilator inside.
So I have a suture already prepared here. I am tightening.
You are like a surgeon, Cacho, doing the.
Yeah, remember.
Like me. No, I know. It's like
this is the house of the surgeons. I have to behave like them. If not, I'm gonna be fired. Now we are going to cross the valve. As usually, we try it from the beginning with the pigtail. If we cannot, we can use the Amplatz catheter.
We will see how Cacho crosses the valve because he has a special way to cross using the JR. Is that right? A JR?
No, the pigtail.
Okay. The pigtail directly.
I could say that probably in 80% of the cases we are successful in this simple maneuver. You have to take some time.
So this is
you know that why I'm doing this is because at the beginning we have problem with wires, with all the wires, and before we have dedicated wires, so we scared about that. So we try to be as less aggressive as we can. So we try to go to the apex of the valve there, like something like this. Most of the cases we can, but some days we have to change for the regular technique.
Which wire is that?
It's a regular
J wire?
Yes. But it's a little bit damaged because we damaged the wire with the angio-seal.
No, and also, the mean gradient is 47. So this is very, very tight.
Yeah, maybe we cannot waste too much time. Give me the Amplatz. We will go with the regular way. Yeah, then don't spend too much time on this. We did it in the previous last week.
Okay.
So let's go with a via recta. Now we are changed for a straight wire, 35, not hydrophilic. Hello, venir. Dale. 3000. So as we were waiting a little bit, we add some additional heparin. So
many people is not doing the working projection with angio. But I think it's good. Sometimes you have some discrepancy in between the.
Dale, sí, oblicuo derecha. Right oblique. Here
I
is
see.
where we have to take care. And when the catheter jumps, if the wire is looped, it's okay. If the wire is not looped, we have to be careful. We are
Yeah.
jumping against the wall. Give me the amplats. I will give some loop here so
Yeah.
we can.
It's triggering some arrhythmia because, of course, we see
Yeah.
the tip
So
of
we,
the catheter touching the LV. So we will be very careful.
I think we can
Which wire
start
are you using
preparing the
now?
wire. Juan. Amplats just to change the catheter.
Oh, okay.
Toma.
We use the
Leave it there.
long J
Yeah.
wire for this.
Okay. Now give me the pigtail. And bring the other pigtail. Fernando, how frequent in your center are using, let's see, balloon expandable versus self-expandable valves?
I would say that,
give me a second.
yeah.
We have to say that we have explained before that in Argentina, many times physicians don't decide which device can use because health insurance companies send to us. But
Yeah.
beyond that,
Yeah. So beyond that, if I have to choose, I probably would choose for a balloon expandable in 70% of cases and self-expandable in 30%. In Argentina, we have availability of Myval and Edwards. We are very comfortable with Myval, so we have been using for the last couple of years. Second valve probably, in between Accurate and Medtronic and Evolut. But as you say, many times we cannot choose, so we have to adapt the valve to the patient, which is better to go inverse.
Let's explain to the audience. So the health insurance send the device that you might have to use it. If you want to change it, you can, but you have to do a long errand. So you have to balance how much time you have to wait and how much different would be your selection. Do you agree on that?
Exactly. Yeah, advantages, of course, of balloon expandable valve is the rate of pacemaker. And that helps us to discharge the patient the next day in the majority of cases. Although some cases we can discharge the patient the same day. So it's that way it's reduce also hospitalization.
How? Ya te di cero, tipo. How do you select patients for same-day discharge?
Well, it was only a very
Franco,
short experience of 6 cases up to today, but I was talking with people from the US that they are, in some cases, in some hospitals in Dallas, they are discharging 20% of cases the same day. So I am more motivated. So first of all, an expandable valve has to be. Second, or maybe the patient that has a pacemaker from before. The patient should not have any electrical abnormalities and should have a very good follow-up. Very nice curves of the hemodynamic.
Yes, you can see there that we have almost 90 peak gradients.
Wow, tremendous.
Wow. This is
I
very
hope we
high.
can cross.
Yeah. What do you think to change to
I would change.
Okay,
I would change.
Listen.
I would change.
Being young is changing your mind when it's necessary. Give me the 18 millimeter balloon.
18.
Ahí tiene.
Yeah, because sometimes you have a strategy, but you don't need to keep very strict. You have to see how patient behaves, and see. Now I see the calcium. Of course, the calcium is not much, but it's nice and very tight.
Vamos a la posición. No, vamos primero. Let's go first a esa. Sí. Sí, dale.
So working projection Now
we will do
it's-
both.
Okay, great. So we can see if we have both nice working projections. So first of all, we go with cusp overlapping,
Okay.
which is
Uh,
8 RAO and caudal 27.
let me check. I think it's a very nice
Yeah.
projection. Maybe we can do another one because we have a lot of water in in the system. Okay, let's
Beautiful.
go to the other. Vamos a la otra, a la izquierda. Let's go to the left. Supposed to be the
So the
coplanar
coplanar view, we should see, of course, the right cusp in the middle.
How much? ¿Cuánto era? Okay, 13 and 0. One
13
more,
left.
one more. Okay. Centralized place there. We will see. Maybe I can do an ancho a little bit higher so we can see the 3 cusp much better.
No, it's not. It's not a good view for coplanar. I'm not sure if we should, keep going, but it's not. I think the right and the non-coronary are very much in the same place.
So probably let's go more AP.
Yeah.
Más
AP.
AP.
Hey, maybe a AP 00 would be.
Here. This is the coplanar view.
Okay. Yeah. It's very. You cannot see very well the right, but we can see from here.
There.
Exactly.
You can see
Yeah,
the right.
It's not
in the middle.
Yeah, very.
So it's 0 at 0.
Good view.
So when valve is ready, we are going to predilate. Is ready the valve? Okay.
Yeah, he's
we have to
preparing
wait.
the balloon because we were planning to go directly. So now we changed our mind.
What about your sealing, Fernando? I know you use only one ProGlide in most of the cases.
Yeah,
Tell us about your experience.
in the last, I would say probably 5 years, we have been using only one ProGlide in every case, regardless the size of the introducer. And we are very happy with that strategy. Of course, it's less expensive, first of all. Secondly, we believe that we have less pure
when you are ready,
complications.
we will predilate.
Sometimes with the 2 ProGlides, we found
help him with
some femoral stenosis. So using one ProGlide is very rare to have any stenosis. So one ProGlide, but has to be ultrasound guiding femoral puncture. The other difference to Oscar is that we use the radial approach as the secondary access. So we use radial and femoral. We don't leave any wire and we don't control the femoral access. Angiographically, nor ultrasound. So it's just clinically, if we see that we have a good sealing, we just remove the wire at the end when we close the ProGlide. If it doesn't close, we can use a second ProGlide at that time. It's not very comfortable to use a second ProGlide after.
When we have started to use one single ProGlide, but in combination with the angioseal. So what we usually do in these cases is to close the first ProGlide under over the wire and with the 6 or 5 French introducer set. So if everything is almost okay, we introduce the angioseal. We pull the angioseal completely, the tighten of the knot or the thread of the ProGlide, and then we close the angiocylinder.
Interesting. So a combination of both.
It's, I've learned in Europe
seen
from
that
my
before,
friend.
or-
Yeah. I learned from my friend Marco Nocci in Slovenia.
Okay, good, good. As always, we learn from each other,
Well,
and it's good to.
this is the importance of live cases. Dame una casa, Franco. And why?
But particularly in this lady with a bit large
Yeah.
groin, I think it's a good idea to use, two proglides, because it's not easy to realize that the patient is bleeding.
Yeah, we have vamos a la oblicua derecha. We have had cases, and actually in a live case, that everything was okay here in the surface,
Except,
but there was a retroperitoneal
Ah.
bleeding, which is not that easy to see in such a huge lady. Mostrame la punta. Show me yeah. So there we inflate the balloon, and I don't remember what else. Mostrame que se vea la punta. Okay, perfect.
so now he's,
Sácalo.
this
Leaving the wire
also
in the-
part of the intervention is very important, to very close and meticulously put the wire. It's a confida wire, is that correct?
Yes, it's a confida. I showed in the last case, but I am trying to take the advantage of having you here and asking you question about your technique and so on, because we have explained that we usually reshape the confida or the safari for a smaller loop, distal loop, and also a secondary vent, especially for self-expandable. It's much easier to retrieve the nose cone when you have this this secondary vent.
Yeah, I've
So,
seen how you put the second. Also, you make it smaller.
yeah. So always try to make a very small distal loop.
Okay.
Here probably it was a little bit deformated, but so let's go people 180.
What? So these are 18 balloons.
This is 18 balloon. Yeah.
Is how is the name?
Inflation.
Mammoth.
Listo.
Mammoth balloon. So we are pacing the patient.
Okay, stop pacing.
Stop. Cortar.
Stop.
Marcapaceo. Cortar marcapaceo.
Cortalo. Cortalo del todo.
Good.
Perfect.
So good shape of the pressure and of the balloon.
Que no se venga para atrás la guía. Dejarlo bien. Yeah. So Juan is going to bring the valve. Carlos is trying to leave the wire as distal as he can. So to have enough space for the nose cone. So we are doing
Do you
okay.
have the introducer? Have you dilated with 18?
No yet.
So we have. So we have
Give
to.
me the 18
first of all, the dilator.
Yeah.
So we will. Some people doesn't expand the dilator with the 18, as we have talking yesterday with a group. But we always increase the size of the introducer with the 18, so the valve can navigate easier.
Teneme el sheet, Franco. Okay, so, Fernando. Yeah. Actually, she felt something when we introduced this big.
Good, I did something.
Yeah.
A great help.
Yeah. No, your help is great. So let's go here.
We will check the valve before going out of the introducer.
Okay. Pone AP.
Fluoroscopically, just to make sure that it's in between the balloon. So go.
Mostrame abajo. Un poquito más. Okay.
Okay, there. You see the tip of the introducer there.
Mostrame que se vea el introductor.
No, could be even close.
Escúchame a mí. Soltar. Ahí. So we can see both the sheath and the wire.
Right. So we'll see. Let's see. So as you see, this is a check that the valve is in the middle of the balloon, because you have the points that are very well distributed. So this is a good checkout. And now we know that we are fine. Right.
So probably we can describe something here. First, we don't have to load the valve as we had to do with the other balloon expandable valve. And also the sheath is a deflectable sheath in the same way. Is that correct?
Exactly.
And do we have to pull here or something like this before delivering the valve or no?
No, we only have to advance.
Okay.
And before crossing the arch, we have to deflect
Okay.
50%.
Mostrame arriba.
So at this point,
Okay.
we deflect 50%.
Now we are deflecting. We are deflecting a little bit more
Yeah,
to cross the valve. And now we are almost in.
great. This is how
Let's
usually.
zoom. Yes, guarda.
So now we will pay attention to the position.
Mini test, mini, Franco.
Pero andate a la proyección.
Vamos a la proyección de trabajo, oblicuo a
So we
derecha.
will go always to the working projection, which here in the cusp overlap.
I think we're a little bit deep.
We are deep, exactly.
So here we are in the,
Yeah.
darkest second band.
Let's do angio just to make
I will
sure.
show you.
Angio.
Sí.
Yeah, it is low. I would go like 1 millimeter
Okay.
above that.
So you rather choose the white bundle
Exactly.
or the
Or
yeah.
the dense just okay.
probably there.
Okay, good. Let's check.
Yes. So we will have a shortening.
Do
From
you have deflected?
Yeah.
Yeah, probably I would take
Complete.
out the reflection. Or you want to keep it?
We can. No, I think it's worse.
Yeah. Just to understand how it's going to open.
No, I think it's there.
Okay.
We can pull the wire a little bit.
Oh, it go below. It
Yeah, because I pull the wire.
Even you're pushing the wire just to take the valve.
Yeah.
Good. That's
So
good.
I think it's
Right.
there. Test. Okay. I like it, Fernando.
It's a good
There.
place. It is a good place. Yeah.
Okay. Now we can leave the pigtail there.
Yeah. You can leave it.
Yeah. So second, we will start pacing at 180, 180. Ojo con la nora. 180, rápido. Sí, está perfecto. 180. ¿Qué pasó con el pacing? Okay. Now, go. Go all. Okay. And pushing a little bit, deflate. Perfect. Stop.
Very nice.
Stop.
Cortarla.
Cortar el marcapaso. Give me the amplats. Wire. Marcapaso a 50.
I think was a great implantation. We see some change in the QRS, the ECG.
Yeah, some enlargement. Yeah.
But
The
I see
position
the
is
pressure.
high.
The pressure went up to 5. So it's a great. Usually
Mini
we
test.
improve the pressure up to 5.
Test.
Now it's good to take the balloon out.
Yeah.
To assess.
Okay. So I will retrieve some. And now we can do an
pressure is fine.
Here.
We have a nice diastolic pressure also.
Let's go. I think it's
Beautiful.
Foreign actions are perfect.
I think this is a great view because there is no parallax.
Let's go to the AP view.
Beautiful.
Anterior.
Even you can pull the wire. You don't need to.
I like to measure the gradient.
Oh, yeah,
like
good idea. Good idea.
Yeah. Maybe we can measure the gradient first, and then
Let's do that.
Please retrieve, Carlos, or hold it the groin. Give me. Because we have to pull hard. I don't want to hurt Dr.
So this is,
Carlos'
I mean,
hands.
how easy the valve is. The balloon expandable valve, especially this valve, has good advantages in terms of aortic regurgitation, the AR. Has a very good sealing, and in these good sizes, it's very rare to have any gradient.
Facing is moving.
Probably it's not a good valve, the balloon expandable technology in small annulus that in those cases, I prefer to have a supraannular position of valve that is in a self-expandable technologies.
Let's go for 0 again.
Which is the second pressure? The second pressure.
Let me check the zeros before.
So one is LV,
Yeah.
and the other one is the radial.
No.
Oh, aortic. Great.
No gradient at all. Very nice diastolic. Very nice notch indentation.
Beautiful.
So now we can
shape
pull the wire.
Of
Give me
hemodynamics.
the G wire. And we can also ask for echo because we still have at least 10 minutes more.
Yeah.
This room. Fortunately, Fernando, you come so we could talk a little bit.
Sure.
Because last week I was in too, I mean,
Talking
faster than I should. So there was remaining time that it was free. So
this is a good point to discuss.
Dr. Samir regret me. You were too fast.
So another point
let me
to discuss is how long are today the TAVIs? And TAVIs are now a very short time for the procedure. So usually it's 1 hour, 1 hour, 15 minutes for all the setup and everything. No error at all. So this is the
ahora sí,
thing.
¿puedes ver el eco?
And the position is great. It's like 3 millimeters below. You have a great access to coronary arteries because the cells are very large in the top, as you see.
Now we can see what she can see on the echo.
So what is she gonna check? So she's gonna check, first of all, to the gradient, the amount of AR, mitral valve function, and if they have any pericardial
effusion.
Effusion.
Okay, trae el arco. Tráelo. Okay. Okay. Enough. So one question, Fernando, to retrieve the sheath, you put the introducer before?
Yeah, please. Yeah. Always put the 18, the larger dilator. This is a good point to here.
Could you turn on the lights on so we can see the suture a little bit better? Not this one, because if not, there is a lot of saturation on the camera. This one. Yeah, thank you. Sí. Córtalo.
And I think, in this kind of patients, 10 years ago, we have sent this patient to surgery. The follow-up, how the patient feels after the intervention. So this is something that is a great advantage for medicine in general.
Perfect. So no leak, only 7 millimeter gradient. ¿Podemos retirar?
Mean gradient 7?
Yeah.
Good. Excellent. The usual.
Yeah. No the AR. Oh, here we have some problem because the hole is too deep, so it's very difficult to go down. Libera un poquito. Okay, you can see that it's almost the whole proglide inside the skin. So we might have to inflate the balloon here. Tráete un balón de 17.
So what
too deep.
he is doing is inflating the balloon that is coming from the other groin to do hemostasis
Yeah, because
during
it's too deep.
the suturing.
Mostrarme abajo. So we still have the wire there. Probably we should retrieve the wire. Or we can try to put the ancho seal also. Give me an ancho seal. If we can go with the ancho seal, we can put an 8 French ancho seal because it's too deep where we are.
Just to make sure.
Yeah.
Good. Before going off,
Yeah.
thank you, Cacho,
Yeah.
for inviting me. It was a pleasure to do this live case together.
No, it's our pleasure having you here. So maybe you can comment your experience with this valve. The cases you have done here, you are proctoring.
Thank you. So we have almost 100 valves. So I think it was 85, 86. These, the rate of pacemaker is less than 10%. We haven't seen any very important, complication. We have a couple of ARs that were not due to the valve, but more for the positioning. So we have to make sure that the positioning of the valve is correct. It's probably the most important moment of the intervention is to have a good, fluoroscopic view of the valve parallel to the annulus and see the position. The rest of the intervention has become a very easy and simple procedure with a very low mortality. We have been using cellular protection in some, I would say a third of cases. This is another point to discuss if we have to believe in the trials or in the experience. But we are very happy with the procedure, with the rate of complications, and how this intervention is growing.
So we have improvement, but we still have bleeding. I think it is too distal from the skin due to the obesity, and that's why probably suture is not going perfect to the place. So we will inflate the balloon there. We will check it if we have bleeding.
So you're going with a 7 millimeters balloon?
Yeah.
So the same size of the common femoral.
So we had to, comprimí un poquito. Tenemos que revertir la heparina del.
So we are giving protamine to reverse the effect of heparin.
And probably, sacan la mano. No. Le podemos hacer un poquito más porque le hicimos heparina hace poco. Y if we don't have sealing, I think we have to compress and it's going to be okay.
We'll see the EKG, how it is in the next few hours. Many times, the left bundle block that we have now reversed with the time, but we will see. So far, it is a sinus rhythm. The PR is, short. The only change is left bundle block.
So here we will leave the balloon for 3 minutes. In case we have bleeding, we can think about to put a covered stent. So this is the patient that we never think about surgery because she's too big. The possibility of having complication with surgery is very high. Lymphocyte infections, we have had experience, so it's much better to deploy a covered stent and finish the procedure. And the patient for sure is going to go very well.
Now, what kind of cover stent, if you have to use?
For this patient, such a patient is very easy to put a balloon expandable stent because For a self-expandable stent, we have to use the 9 contralateral sheath, 9 French.
Mhm.
So with this 7 French, we can cross over. We can put a sheath, a crossover sheath, and over this 018 wire or the 035 wire, whatever wire, we can deploy the balloon, the cover balloon stent. We can do the test with the sheath, and for sure it's going to be okay.
Good.
So, okay. At the end, what we are showing here is the TAVI, field still need development of closure devices.
Yeah, this is a good point.
Valves have been developed faster than closure devices. We only have very few. We don't have MANTA here in Latin America, but to be honest, I don't know if there is a huge difference between suture-based and plug-based devices.
Yeah, that's a good point too, especially in these very obese patients.
So from the echo point of view, you probably have seen that the peak gradient was 15 by echo, 7 the mean, with a good valve area and not regurg at all.
What regimen of anticoagulation or antiplatelet regimen are you gonna use to discharge the patient tomorrow?
Oh, excellent question. I don't have a proper answer. We are using the ADAPT, but to be honest, it's probably by default. If the patient is under EF, of course, anticoagulation and probably nothing else. If the patient have a stent, clopidogrel or usually clopidogrel in these very old patients, plus anticoagulation if under EF, or DAPT with aspirin if on normal renal
Function.
sign. Yeah.
Okay.
But and then it's okay if we are on DAPT, when we stop it. Probably at 3 months we stop and change. Yeah, but not sure. I have to tell you that this is not something not completely sure. It's physician dependent, I would say.
Yeah, of course, we are following some consensus. The consensus has changed. The trial comparing aspirin compared to dual antiplatelet therapy are beautiful, beautiful. No bleeding at all.
So guys, our job is done here. Dr. Carlos Fava is gonna fix the wire of the pacing for 12 hours or at least, and we will pull out or withdraw the contralateral sheath. While Franco, although we don't have a bleeding, we still compress probably for 10 minutes, additional 10 minutes.
Good, excellent.
It's just safety measures, and Carlos is gonna suture the skin. You are released. Thank you so much.
It's a pleasure. It was a pleasure.
And you are very welcome wherever you can. And I move to the other room.
I have enough, travel there. So.
Yeah.
Thank you very much for the invitation.
In the other lab is Dr. Lev waiting for me.
Chicos, nos vemos. Gracias.